Next on primary care, kidney failure. Black Americans are 3 times more likely to suffer from kidney failure than their counterparts. Hello, I'm Dr. Lonnie Joe, and welcome to Primary Care, the show dedicated to improving the health of African Americans. 1 in 3 Americans is at risk for kidney disease, and if you are African American, your risk is even higher. Black Americans have a much higher rate of high blood pressure, diabetes, obesity, and heart disease, all of which increase their risk for kidney disease. Access to care and other social determinants of health are also believed to play a major role. Here today to talk about renal failure and the epidemic taking place in the Black community is our special guest, Dr. Jason Denney. Dr. Denney is the Director of Center for Living Donation at the Henry Ford Transplant Institute. He is one of only 50 African American transplant surgeons in the country. Dr. Denney, welcome to the show.
Dr. Joe, thank you very much for having me.
Jason, it is certainly a pleasure having you on the show today. I understand that your brother is also a transplant surgeon, one of the 50.
Yeah.
That means we've got almost 5% of the African American transplant surgeons with the last name Denney right here in this country.
Yeah, it's kind of an odd fact, but yes, it is true.
We're honored to have you spend some time with us. Why are we having what many consider as an epidemic? Why are we having so much kidney disease and renal failure in the Black community?
Well, with 50% of the people waiting on the waiting list to be people of color, it's the diseases that are their primary care diseases that chronically lead them to renal failure, and then ultimately the ones who are fortunate enough to kidney transplantation. And as you mentioned, 50% of those people waiting on the list typically have hypertension or diabetes. There's a number of other diseases that can cause renal failure, but the bulk come from that. And there are predispositions for that, environmental and genetic as well.
So if we were to talk about or look at the early warning signs of kidney disease, what kind of conversation would we have with patients?
I could tell you probably half of my patients have very little symptoms. An example would be a gentleman was a truck driver, changed his trucking business and got a physical. And someone told him, hey, you have kidney problems, and he knew nothing of it. Other people tend to have problems like fatigue, swelling, sometimes foamy urine, things of that nature. So they can be relatively subtle until the disease is has progressed quite a bit. And then they could be more dramatic with significant shortness of breath, things that limit your daily activities. And those are the things that really bring people into the office because they can't do the things that they want to do any longer.
Dr. Denney, with that in mind, we should be considering this disease as an ongoing situation in primary care that needs ongoing attention in order to stay ahead of the deterioration that occurs.
I think that is very true. Not everyone who has hypertension or diabetes will require kidney transplant or even dialysis. However, those will be the initial diseases that put you at risk. And certainly, if we can address those prior to them becoming severe, then these patients will not need any sort of renal replacement therapy of any kind.
You know, Jason, we always get the question of, can kidney disease be reversed? Where do we stand on that now?
For the most part, by the time the person needs to see me as a surgeon, we're not talking about reversal of disease. If you were to biopsy these kidneys, which many people have, you will see that the functional unit, the glomeruli of the kidney, is severely damaged, and they have a lot of scarring. And the measurement of their kidney function, one of which is the glomerular filtration rate, is significantly decreased. When you have early kidney disease, some of that can be reversed. And there's some ongoing studies for certain vitamins and things that can help. But I always tell people that your kidney function is deteriorating from the day you're born. It's just that your kidneys will last you for most of our lives. But if you develop a chronic disease like hypertension or diabetes, now your kidneys start going down at a faster rate than your life. And then you turn 50 or 60 and you're still alive and your kidneys are not functioning.
Correct. You know, I'm of the belief now, like people know what their blood sugar, blood pressure, or A1C is. I'm beginning to think that, especially in high-risk populations, they need to know what the GFR is, and you mentioned that. Expound on why that measurement becomes of paramount importance in us treating renal patients.
So in brief, basically your kidneys are a filter. Think of it as a colander, like you will drain vegetables or salad in the sink. As you get older, you start to let more and more things through and your filter becomes less efficient and your filtration rate number will go down. So let's just say you start with 100, right? You generally are not eligible for transplantation until your glomerular filtration rate is below 20. And you'll probably start having symptoms at about 8 to 10%. So if you are 50 years old and your rate is 70%, you're still very good, although that's not the rate that you were when you were 20. But knowing it, I think, is a good idea, as long as you know how to interpret it. So you need to have a good relationship with your primary care physician so the information is utilized appropriately.
Right. So knowing that number is going to depend on the relationship with the primary care physician or provider, and also being able to interpret that number properly based on age. Absolutely,
because at different ages, the number expectation will be different. It wouldn't be abnormal. But in this age where there's a debate on who owns medical information, the patient or the hospital, patients are getting more and more information. And I just want to make sure that they can utilize it to their benefit.
So here we are facing pretty much an epidemic in terms of people with progressive renal disease, and they wind up in these stages where they're kind of in a waiting situation. We're watching what the numbers look like. What should we be doing to pay more attention to these patients in terms of treatment and also in terms of prevention?
So the best thing they can do, if the stage is appropriate with their age, just continue living a healthy life. If you are a younger person and you have accelerated kidney disease, then the best thing to do is follow the instructions of your nephrologist if you're at that point, and modify your diet. Sometimes patients think, well, I'm going to just go on high protein. Well, that's not a very good thing to do. They pick the diet of their choosing. Generally, healthy lifestyle and maintain a healthy weight is probably the best thing you can do. I'm not aware of any peer-reviewed study that will improve people's kidney function once they reach stage 3 and 4.
Basically making simple, wise choices.
Absolutely.
Jason, we got lots of questions concerning transplant, and I know you're anxious to get into it with us. We have to take a break. Stay with us. We'll be right back with more primary care.
Whether it's advice on managing your anxiety or tools to help you stay grounded, Coping-19 provides a range of resources and self-care tips to help you cope with this pandemic. We can help. Find the resources that work best for you at coping-19.org.
Type 2 diabetes can have a big impact on your life. But how can it be prevented? Well, the first step is knowing if you have something called prediabetes. Take the 1-minute risk test today at doihaveprediabetes.org.
Welcome back. We're here with Dr. Jason Denney, who is the Director of Center for Living Donation at the Henry Ford Transplant Institute. Jason, let's move a little bit to the COVID realm since it is the topic of the day. Why are kidney transplant recipients at a higher risk for getting COVID-19?
Well, when you get a transplant, you make an exchange. And the exchange is a life on dialysis and a shorter life for a longer life with a kidney transplant, but you also have a lowered immune system. And they do that so that your body doesn't fight the new kidney. However, that increases your risk for infection. Doesn't mean you're going to get an infection, but it increases your risk. So now you add COVID to that. It's very infectious. We have it spreading through many states. And it's been almost 1.5 years now. And with a lower immune system, you have less ability to fight the virus. And that is a very, very big problem in all immunosuppressed patients, including cancer patients and autoimmune disease patients.
So those category of patients need to be near the front of the line.
I think so. And they need to be very judicious. because you might not get a second opportunity. The mortality rate is significantly higher, and the amount of resources you need. One of the issues with COVID is that patients get admitted to the hospital and it's resource intensive. Many nurses, ICU, ventilator. You may live and go home after being in ICU, or maybe not, but that's weeks. And that is really what stresses the system. At Henry Ford, we encourage patients who are on the list to be vaccinated, because prior to lowering your immune system, you have a greater chance of the vaccine working. So when you get the vaccine, your body basically takes a snapshot of the virus, and the next time it sees the virus, you can be protected. If you get the vaccination after your immune system is low, most of the current studies show that your body's not actually able to take that snapshot adequately. And there's further studies saying that maybe you can get 3 doses as opposed to 2. But in the meantime, until that is all cleared up, you're at significant risk. So the short version is, if you're on the wait list, get vaccinated. If you're post-transplant, also be very judicious. Wear a mask, avoid places that are increased vectors for transmission.
Right, some of the sickest patients I've seen in an ICU setting are those who are immunosuppressed, and I'm sure several of them were transplant patients at this point. Really some devastating outcomes simply because they present the most challenging cases. Right behind that are people who are at high risk, especially like you mentioned earlier, if they have high blood pressure, diabetes, respiratory disease, pre-existing renal disease. We face and present a special problem in terms of treatment and the kinds of resources that need to be promoted and provided for those populations of patients. But let's move on to renal transplant a little bit further. So we're dealing with this patient. They've gone from stage 3 to stage 2. Like you said, the GFR is now getting below 20. What are the next steps on the primary care part that we need to be listening to in terms of getting patients like this into the hands of nephrologists and people like yourself?
Absolutely. So as the person progresses through their kidney disease, they should be referred to a nephrologist, and that person will, do some more intensive tests, find out the true cause of their kidney disease, sometimes with a biopsy where they take a very small piece of the kidney with a needle, and institute some other treatments. Some autoimmune diseases can be treated with steroids and other immune modulated drugs to preserve kidney function. But let's say they have diabetes and their kidneys are basically just not going to work. Then, your doctor should refer them to see me at a transplant center and the team. At that time, we'll be evaluating them psychologically, physically with our transplant nephrologists, social workers, financial to make sure that insurance is appropriate, and we will schedule them for a procedure at the appropriate time. Now, I tell every potential recipient, the single best thing you can do when you're at the point that you're going to need a transplant is to see me relatively early and to find a live donor. And at the Center for Living Donation, we specialize in, one, helping you find a donor, and also treating your donor with a concierge level of service. Because when you know that your donor is going to be cared for, and all the statistics say that they're going to be well, they're going to go home in 1 or 2 days, we take the kidney out with the camera or the robot, you feel much more comfortable having your grandchild or your son or your wife donate. And we do that regularly every week. So that is very important. A live donor is a key because the wait list time in the state of Michigan is roughly 5 years to wait for a kidney. That's a long time to be on dialysis unnecessarily. So it's very important to get the word out. And we have a variety of ways. We utilize social media. We have an app that we allow people to put their stories on the internet for the people they choose to see them. And then we take care of everything. No one calls them. They talk to the center. And that's shown really pretty good results.
So basically, Dr. Denney, you guys are very involved with the patient's care, that intermediate step called dialysis, before they actually get to the point where you're saying you need to be on the list, we need to start looking for a living donor, etc. You're involved in dialysis. Now, as you know, this has become a significant problem for the population as a whole, and certainly in the African-American community. What are the challenges with dialysis as we face them now? Because patients always have issues on dialysis.
So you can live on dialysis. However, we know that patients on dialysis versus patients who receive a kidney transplant, the ones on dialysis will die sooner. We know that. So kidney transplant is life lengthening and life saving. Dialysis, typically the negatives would be, you have to have a fistula, typically. Sometimes it gets clogged. I do all those operations. That has to get fixed up. You got to go to the center 3 times a week. Rain, sleet, snow. You can get some dialysis at home. I encourage patients who are able to do that. I think that is a very good option. But the transplant is really the thing that gets you back to life. It gets you back to doing all the things you could do up until the day the doctor said that you need a kidney transplant. I can't make you 19. Not all of us want to be 19 anyway, depending on what your 19 years were like. However, I can get you back to when the doctor said, there's a problem with your kidneys, ma'am or sir. You don't get the fatigue associated with dialysis. Many of my patients tell me Monday, Wednesday, Friday dialysis. Right after dialysis, I'm done for the day. And that's it. And I think kidney transplant gives you your life back.
Well, Dr. Denney, you may not be able to return them to 19, but you might be able to help them get to 90. We're up against a break.
Absolutely.
Don't go anywhere. We'll be right back with more primary care.
The COVID-19 vaccines can be our chance to get back to our plans, to get back to each other, to life. But it's okay to have questions, like, can the vaccines give you COVID-19? You cannot get COVID-19 from a vaccine. Find the latest information at getvaccineanswers.org.
Our dear fellow Americans, vaccines are a huge step forward. We still need to do the simple things that we know work.
Wear a mask, wash our hands frequently, and maintain social distance.
Now it's up to you.
Welcome back. We're here with Dr. Jason Denney, Director of the Center for Living Donation and Senior Staff Surgeon at the Henry Ford Transplant Institute. Dr. Denney, as an organ transplant surgeon, you see racial and health disparities surrounding kidney failure and transplantation from a slightly different lens. What are some of those disparities that you can bring to light today?
Well, historically, African Americans were coming to transplant at a later time, which means their referrals were later. It's been reported that some of the outcomes are a little worse.
We're getting to the game. We're getting to the game late,
and that's unfortunate. A few laws have been passed to help that in recent years. That your waiting time doesn't begin once you were diagnosed, but once you started dialysis. So even if you were sent late for whatever reason, you will still accrue that time. And there's several organizations in the community to help that. I was chair of MOTEP, which is the Minority Organ Tissue and Transplant Education Program in Detroit for many years. And we did several hundred activities a year educating people about organ donation. That organization was started by Dr. Clive Callender, who was the third African-American transplant surgeon ever, who is still in Washington, D.C. and contributes to the transplant community.
Yes.
I think those sort of things, awareness, education, educating physicians as well to the benefits of transplantation. A study done many, many years ago said that African Americans did better on dialysis than their white counterparts. And that's been a reason historically why people felt, well, dialysis was just okay for some. That's since changed, but those attitudes linger in some people. So, we tell everyone, send a patient to us, we'll determine if they are an adequate candidate or not.
So Dr. Denney, we travel the country and getting back to traveling the country at least, but even before COVID, we saw it seems like a plethora of dialysis centers springing up in African American communities. Did this represent better service line or more disease burden? I
couldn't answer that specifically, but one of my colleagues out of Chicago speaks very eloquently, I don't have the reference on the top of my head, about disparities by neighborhood of resources, from groceries to pharmacies to dialysis centers. So I suspect that it's a combination of both. There is a need, but there is also the economic push. And most things don't get done without the economic push. And dialysis is reimbursed. So I think people feel okay with opening dialysis centers.
So basically, the challenge remains. This is a devastating disease state that we find ourselves attempting to treat and treat better. But a lot of it goes back to what you mentioned at the outset of the program in terms of lifestyle and treating other diseases that definitely affect the kidneys in an adverse manner, treating them properly. But it seems to me that you guys at the center are doing an excellent job of incorporating the entire patient experience in terms of getting involved with them long before the transplant is even needed. So I want you to give the center another plug in terms of how widespread your involvement is with these patients, because we've had some personal experience.
So the Henry Ford Transplant Institute is 360 degrees of care. And we developed the Center for Living Donation specifically to focus on the donor aspect, the live donor aspect of care, living kidney donors as well as living liver donors. We didn't touch that today, but that is another aspect of it. And what we do is to ensure that when a patient comes in contact with us at the Institute, we now take on the responsibility of ushering them in to a new era of health. And I think that is extremely important. Transplantation is a new life for people, and they feel completely different. And we also need to address the donors and the donor families. Some of the most courageous people that I know are donor families. And at our kidney walk that we have every year at Belle Isle, we honor those families. These are for people who've passed, who donate their kidneys. You know, sometimes on the worst day of someone's life, they thought about somebody else. And I think that that is very, very challenging. And we need to recognize that. With MOTEP, we've worked to help increase with the Gift of Life Michigan the number of kidney donors on your driver's license to over 50% in the state of Michigan, which is tremendous. So many people have heard of organ donation. And I think that we should recognize donor families as well. But to go back to your question, yeah, at Henry Ford, we do a very good job. We have a very large program of very dedicated nurses, medical assistants, surgeons, nephrologists, and consult doctors who specialize in transplantation as well.
Jason, talk to us a little bit about what's coming down the pike. What can we expect in terms of the future of transplant surgery, new devices, new procedures? Give us some insight on that.
So Henry Ford is at the cutting edge of these things, and I'm very happy to mention them. So in terms of the Transplant Institute, one of the things that we've done over the last several years is been able to implant kidneys robotically. Very few centers can implant kidneys robotically and have them work, and we've been able to do that for several years now. The benefit is it's an alternative. It's done quickly. Larger patients can get transplanted. So sometimes if you have a larger patient, BMI is now getting up to 40, 45, it's very difficult to do that operation in the standard fashion. But robotically, it can be done better. We also removed the kidney from live donors robotically as well. A few other things, innovations are finding ways to have people get donors. So we have a donor app study with Johns Hopkins where we take a patient, their family, write up their story, distribute their story through the internet, and using different computer software, we're able to go through several donors for a person. We also have other software called MatchGrid. And what we do is we match people up. So let's say Mrs. Jackson comes in with her donor and they don't match. Typically, that person would just be sent home. At Ford, what we'll do is take that name, we put it in our program, and then we have several other families who have donors that don't match. And then we see how they can swap to one another. And that's what's called a chain. And we've done that many times. And now that person who did not have an opportunity to have a transplant now can have a living transplant, even though their donor didn't match. So these are some of the innovations that we're using at Ford, as well as modifying medications, making sure the medications have decreased side effects on patients. We operate on older patients. My oldest is 80, doing well in the western part of the state. Many centers don't operate on anyone over 70, and we have several 70-year-olds.
That's interesting. Not only are we getting better at what we do, we're able to expand the age category that we provide these services to. That's very interesting. Jason, I'm only half through my questions here, but we're running out of time. But I want to take this opportunity to thank you and all the work that you've done in this very necessary and exciting profession, and basically thank you for your commitment to Gift of Life, your commitment to MOTEP. I think that what you guys have done in the community has been outstanding. We look forward to continued relationships, and personally my family appreciates you and all that you've done in this arena, and hopefully we will be able to do this again in the near future.
Well, Dr. Joe, thank you very much for having me. As a stalwart member of the community as you are, I appreciate that you thought of me to interview today. Have a good day, sir.
Excellent. Thank you so much. Our guest has been Dr. Jason Denney, Director of the Center for Living Donation and Senior Staff Surgeon at Henry Ford Transplant Institute. There's a lot you can do to prevent kidney failure. Visiting your doctor or clinic regularly to check your blood sugar, blood pressure, urine protein, kidney function is a good place to start. Thanks for watching. For Primary Care, I'm Dr. Lonnie Joe.